Hi.
Hi. Welcome, everyone.
Good afternoon.
Good afternoon. Thank you all for being here in our nation's capital for the next few days. Last year, we hosted our first ever Connect conference. I was 2 weeks in as the new CEO at CAQH, so it was quite the introduction to the company, to the team, to all of our partners. And I will tell you, the conference last year was truly impressive. The thoughtfulness of the sessions, the engagement of all of you all, I was just absolutely blown away. It was an amazing way to start at this company. This year, we decided to do it again, so thank you so much for joining us for our second annual Connect conference. We've planned another very informative, provoking, and also fun conference. We really want you all to have a good time while you're here. I'm thrilled to kick it off with our session with these amazing experts that some I've just met, some I've known for a very long time, and we all have a passion for women's health. It's near and dear to my heart, and I know it's all of the panelists as well. Before we get started, I thought I'd take the opportunity to talk a little bit more about the theme of our conference, a return on health. Some of you all may have heard this before. It kind of started about 10 years ago while I was at Humana. So any of my old Humana colleagues that are here, we used this as a term to describe some of the work that we were doing on the proactive and predictive modeling on chronic conditions. So it was a way for us to think about how to get in front of disease progression, how to slow disease progression, but it started with the data. And what we learned is there's two sides to the return on health. One is the financial side. The other one is the human side. The financial side is much more through the lens of the payer. It's about the medical cost reduction that a payer can yield if they get in front of disease progression with different solutions and different products that they offer. Catching the advancement of chronic conditions also help people stay healthy longer. So there's a financial side for sure of the return on health. But the most important part of the return on health is the human side. And that's about making an impact to a person's health and their life when you help them slow disease progression, even stop disease progression, and improve their quality of life. And that's only possible if we help people get the care and support that they need early. So for this panel, we decided to apply a return on health to the concept of women's health, and specifically aging women's health, and discuss both the financial and the human side to help aging women get the care they need early and when it matters the most. So to get this session going, I needed to do my own research. And so I started with the data. I'm a bit of a data geek, and I like to look into the data, and I like to look into our data. CAQH holds about 4.8 million provider data records. That's everything about a provider. Where they went to medical school, what specialty do they have, where they did their fellowship or their residency, and most importantly, where they're located. How do you find them? And then also looked at MPI data and census data. And what we found, and this was very scary, what we found was by 2030, the US is expected to have about a 5,000 shortage of OBGYNs. And that includes providers who deliver care to aging women to treat perimenopause and menopause. So think about it. Women like me, midway through life, maybe a little bit further, finding themselves juggling numerous different things in their lives, responsibilities from raising children to caring for aging parents or other family members, while also working to advance their careers, maybe even at the height of their careers, and at the same time trying to focus on their own health. It's hard to find the care you need. It's challenging because there's greater demand than there's even supply in the United States, especially in the South and the Midwest and the West. So this has great health implications to women. So let's get it started. I'd like to start with you, Gigi.
Okay.
Can you tell us a little bit about the health issues and risks women are facing every day during perimenopause and menopause?
Yes, I do this every day. Even though I'm Executive Medical Director of Women's Services for Norton Healthcare, which we have 7 hospitals in Kentucky and Southern Indiana. I also am a full-time practicing clinician. And so I take care of these patients every day. And in addition to that, I am one of these people. I'm 52 years old, and so all the changes that are coming in complaining about that maybe 10 to 15 years ago I didn't have perspective on, I certainly more than understand now. It is very impactful, perimenopause and menopause, because of the substantial cardiovascular and stroke risk to women at this time when estrogen levels are changing and hypertension's developing and cholesterol's increasing. Those are some of the biggest risks, in addition to the fact that osteoporosis becomes an enormous concern as well, and bone health becomes something that we're talking about, because you all know the data on hip fractures and how bad that can be for people, and the morbidities associated with that. In addition, not to be underscored, is weight gain, which anyone who's been through the process firmly understands, just with the changing levels of hormones in our body and decreasing testosterone and extra flab that didn't used to be there 10 years ago. Just not even burning calories at rest in the same way as we used to. So, talking about keeping muscle mass up at that time. And then, of course, as women gain weight, their cardiovascular and stroke risks go up as well. And then the whole other part of it as well is the emotional toll that these things have on women as well. Hair loss, insomnia, sexual health with vaginal dryness. These are all things that affect women's lives every day and their mental psyche. I lost all my hair last year. This is not real. I'll just disclose this is extensions and fake. And so, and this was the best money I'd ever spent for my mental health. It's expensive, but so when people come in, they look at me and they're like, really? That's not real? And I'm like, no, because I lost all my hair last year. So really, it's impactful in so many ways, not just, again, disease states, but emotional health as well.
Yeah.
Well, how do you follow that? No, I think it's, people talk about menopause and say, well, how do you cure it? Well, we don't cure it. It's a time of life, and there are a lot of changes that are going on. What do I know about this? I'm OBGYN for a long time. Took care of a lot of patients, and also 3 sisters, wonderful mother. Now I have a wife and 2 daughters, so there are a lot of hormonal changes that go on. But I think the most important thing here, and I want to really thank you for just the courage to talk about that. It's those discussions that need to happen. Sexual health. It's the same thing with colorectal cancer screening. Nobody wants to talk about poop. But let's talk about what happens if you don't do colorectal cancer screening at age 50. It's a very inexpensive test. If you catch it early, 95% survival. You catch it late, 9 months survival. And I think that same thing holds true for, what happens with cardiovascular health, with diabetes. Screening for diabetes, you say, well, I'm gaining a little bit of weight. Well, maybe I'm changing my diet. Maybe I'm changing because I want food that's more soothing. I like the sugar. I like the ice cream. I like the wine or whatever. But let's make sure you're not pushing that over to diabetes, because then you start to look at liver function disease that can progress into cancer. It's like, okay, so let's stop and not just look at menopause, but look at life and say, what's happening to not only to the woman, who is still, in my opinion, the center of the family, but the psychosocial unit. And I'm looking at all the guys in the room and say, well, just listen and be sensitive to this, because it doesn't go away, but be super sensitive to what's happening. And make sure that you're thinking about this as doctors in terms of care being at the core of what you do. And you'll have wonderful colleagues like Gigi, talking about these things that are uncomfortable to talk about, but allows us to better move through life, because it doesn't last forever. And again, thank you for that. Wow. Okay.
So, Jannine, why the taboo? Why do you think we were so reluctant to be as brave as Gigi and to talk about it. Like, why is that? Any learnings from your work at Electra?
Well, for those who aren't familiar with Electra, I'll just share that I run a women's health company. We're an early stage company. We offer virtual care, so telemedicine care for women navigating perimenopause, menopause. Our patients range in age from their 40s to their 70s. Most are in their 50s. And we are also incorporating, and I love that you use the term psychosocial, and Gigi, to your point about the emotional well-being, when we started out on this journey 5 years ago with our founding physician, an OBGYN who herself was going through such difficult brain fog and forgetting her NPI number, that she's like, it's burned into my brain and yet it's not there, convinced that she had a brain tumor. And fortunately she didn't, but that was like her wake-up call. So when we started out, it was recognizing there was a lack of access to care in this time of life to treat symptoms, but also the psychosocial support. So we've built in peer support, access to experts, including what we call menopause doulas. So if those are familiar with doulas in the maternal health world, or community health workers, wrapping that into our model, as well as hundreds of hours of education, because that is what we find, and I'd be curious to hear what you think, is so difficult to accomplish in a 10 or 15-minute visit. And there are 34 symptoms of menopause. So that's a lot to cover. That's what Electra does. To the point about why is this such a taboo? I mean, I think there's, I could talk about this for days. We could probably start with centuries of sexism and ageism and lots of isms. We could talk about the systems that inform medical education, and you would both be, suited to speak to that. But I would point out, the WHI, the Women's Health Initiative study that came out in 2002, and disclosure, I'm the daughter of two physicians, including a urogynecologist who studied overactive bladder, menopause, and sexual health. So I grew up as a kid going to conferences like at this Marriott where, that was my school vacation, and my father's presenting to, a room like this on the climacteric. And so it's funny how these things come full circle like 40 years later. But all that is to say, when we got started, it was smashing this taboo. That was the goal, and it was to have conversations that had not been had. And I think we've seen the impact of some of that taboo smashing in the family building space. So we saw it around the fertility conversation, around pregnancy, maternal health, and it felt like perimenopause and menopause was just on the horizon. And in the last 5 years, we've really seen this topic move into the mainstream, which is really powerful. And I think it's a credit to this group and leaders like you all to make that happen.
So Pat, I've heard a couple of people say, can't you just fix menopause with some hormones?
Yeah.
Tell me about that.
Well,
Please.
but I think it gets to the taboo. Just fix it. What's wrong? Why can't you fix it? And as physicians, we're trained to fix things, like orthopedics, bone hurt, fix bone. The delivery, babies, okay, 9 months, you're fine. So fibroids, infertility, okay, fix it. Our mindset is different with menopause. It extends over a 10-year period, and there are a lot of things that go on. So I think that's the reason we can't fix it. And also, it's not something that should be fixed. It's something that's part of our lives, men and women's lives. And so we have to adjust our mindset to not just fixing it, but I'd say embracing it as part of what we're doing with our lives, our spouses' lives, or our partners' lives, but also the lives of the family, because there's a lot going on. And I don't think you should try to fix it. I think we should try to understand it and then move through it, together.
Yeah, I agree. I mean, it's so multifaceted. People come in and they have 30 of 34 of the symptoms written down for me, and they show up, and I'm like, oh, wow, we're not going to get all that done today. And it is hard, because even if I put people on hormone replacement therapy for hot flashes, night sweats, I've also got to add a cream or a tablet for the vaginal dryness sometimes, and then I got to send them over maybe for some medicine for their incontinence and bladder, or evaluation of that, and then the weight gain. Of course, everyone wants something for that. And you know, it's hard because it's multiple things that have to be addressed from multiple angles, and at a time of life where women are probably busier than ever, being midlife, if they have careers or kids, you know, moving out of the house, or, you know, growing up, and then aging parents, and then also then, you know, you do want to address with them not just all the symptoms that they're having, but also, you know, concerns about their cardiovascular health and their stroke risk, and the other things that can be very impactful that are happening because of their weight gain and high blood pressure and high cholesterol, and some people have never been on medicines their whole life, and now you're talking to them about cholesterol medicine and hormone replacement therapy and vaginal creams, and they're like, their heads are spinning because they're like, I was fine until all this started happening, and it's like, well, I know, and so it's a really challenging time of life for women for multiple reasons, and yeah, I know Sarah and I've talked about this, you know, quite a bit. I mean, even just sharing my personal journey and some of the things that, in talking to patients about all this multifaceted approach, and, you know, you are trying to be in your career, and my dad was hospitalized like 10 times in 12 months. I was the only person in the country to help take care of him, and I'm trying to take care of my kids, and then my hair's falling out, and I'm not exercising anymore, and I'm boo-hooing about all the stuff of perimenopause, and then I go into my primary care, and she's like, you have high cholesterol. I'm like, I can't even deal with that right now. Just don't even talk to me about that, and taking a medicine, and she's like, well, you're gonna go get this calcium test on your heart, and I'm like, oh God, really? Well, when am I gonna do that? And so it's just, it is a lot, and I'm trying to take care of my kids and my family and my patients, and it's really hard to find time for myself. And I know that lots of women that come into my office these days have different themes to that, of how hard that is for them to take care of themselves, and let alone when you start mentioning a multifaceted approach, they're just like overwhelmed.
Mm-hmm. And as a healthcare provider, I mean, you're delivering babies and you're taking care of women, and then you're also trying to take care of yourself and your family. I mean, we know that through COVID and through the pandemic, it was so hard on healthcare workers, but I don't think we ever put it into perspective the way you just did, to think about that you're going through this as a woman, but also trying to take care of other people. It's just amazing. So I'm so proud of you, Gigi. You're just so amazing. You are. So I'm gonna turn a little bit to the financial side. Is that okay? Mm-hmm. So Pat, you mentioned this a little bit about getting in front of things like colon cancer, and we have some data that shows that if you do get in front of it earlier, the cost could be more like $20,000. You don't catch it, and it could be $300,000, but that doesn't even count what happens to you as a person and just your overall outcomes when it's later. So it's really hard, though, to quantify the costs related to perimenopause and menopause. And Jannine, you and I have had a ton of conversations about this. How in the world do you get in front of those costs? How do you even calculate those costs? And it's even harder to try to convince a health plan that there's cost associated that you need to worry about. So can you talk a little bit about this and those hidden costs, and how do you find that cost of doing nothing with regards to menopause and perimenopause?
Sure. It is hard. I would say the good news is that we are starting to do it. And we have been able to work with health plans to contract with them based on what we find in the claims data around the cost of treating symptomatic menopausal women. So looking at the ICD-10 codes that exist that are specific to perimenopause and menopause, because somebody could be not sleeping due to hot flashes and they show up with insomnia, but you don't know if that's necessarily associated with menopause or not. So excluding those types of more general codes. And so we did a big actuarial study, and what we found is that I think it was about 2.6 million lives compared to women aged 40 to 60 who have zero menopause-related ICD-10 codes. The menopausal symptomatic population costs about 50% more. And that's just the folks that have have had some sort of primary or secondary diagnosis. We know that most folks, that is undercounting dramatically. But you start where you start. And it's actuaries and researchers that have been doing this work, including folks from the Menopause Society. So people have looked into the cost of not treating vasomotor symptoms or hot flashes, both in terms of direct medical spend, because we see increased utilization across every category, and in terms of productivity losses. So working with employer data to be able to calculate absences. And I mean, I think sometimes we have to think about this sensibly. Even if we don't have the data yet, we just have to think reasonably. So behavioral health is a good analogy in my view. If you think about where behavioral health, mental health was 10, 15 years ago, before we had this like ironclad sense of ROI, it just made sense, and we had to start from that premise and then understand, well, if somebody has depression and anxiety that is not being treated, probably it's going to impact all of their chronic comorbid conditions. And that's where the spend, I worked in behavioral health a long time ago at a startup, and that's part of what that conversation was evolving to reveal. I think it's similar in the menopause milieu, and would be interested in my panelists' thoughts, co-panelists' thoughts.
It's something we struggle with at Quest all the time, and I think every large employer, what's the return on your investment? What's the ROI? And every health system, can draw blood, can do colorectal cancer screening, but, how do I see the yield on that? Because I get paid as a health system to take care of people who have chest pain, who need heart transplants, and, I don't get paid that much to screen. And it's not that, I think kind of the system's a little bit upside down because the system's designed to react. Okay, so how do you change that? And I think you were asked me about it earlier, what about direct to consumer? What happens there? And I think that, I'm a huge fan of that because it empowers each of us to get our diabetes checked, get a hemoglobin A1C, check a cholesterol. And if it's normal, okay, fine. If it's 500, you might want to see somebody, or if your hemoglobin A1C is like you're thin, you're fit, you think I'm exercising all the time, and it's 8, you might want to see somebody. If it's 3, okay. But I think that that's where we're going to be going. Because it's so hard to get into the doctor and it's so expensive to get into the system, you're going to see a lot more people like you kind of coming direct to the consumer and empowering all of us, to do the right thing, to become knowledgeable about our health care. So I think that going forward, that's the way we're going to balance this financial beast that we're dealing with right now with our high copays and whatever, and just going to the pharmacy and getting a test. It's going to be simple, available, and you're probably not going to need to have a doctor evaluate it because you can read and it says normal. I'm normal. That's good. It's kind of like a pregnancy test. It's negative. Negative. It's positive. Okay. I mean, we've complicated it to the point where it's expensive and it's kind of mystical. And I think we're going to demystify it, and it's going to be cheaper because we're going to push it back into the consumer's hands. Mm-hmm. And that's the way we manage the finance. Yeah, go ahead.
Can I jump in again?
Oh, of course.
So what it makes me think of when you were saying that is just the breadth of the population. And we're talking about more than 50% of people, and for whom this is going to happen if they live long enough. And so even if the savings is small, relatively speaking, the breadth is enormous. And so the opportunity is actually huge, and the cost of the intervention is not so great. A lot of that can be done, as in our experience, through allied health professionals, through education and support, and then the right clinical interventions at the right time, some virtual for low acuity and reasonable settings, and then directing to the right folks. And I think that is just worth bearing in mind when we talk about ROI in this space.
Yeah.
Well, and I think that it is so large. I mean, for women in this age group, we're looking at, did they get their mammogram? Did they get their Cologuard or their colon cancer screening? I mean, did they get their cholesterol checked? How's their blood pressure? How's their emotional well-being and their mental health? How is their weight? Like, it's so many factors. So, like, I can see how the ROI can be very difficult to calculate because of all the different spokes on the wheel that have to do with this time of life for women. But also if you look at it, like, women are usually we decide healthcare for our families. So, if we're going somewhere and getting care, bringing our families there. So there's some ROI there that's not probably easily identified also if we're seeking care and taking care of ourselves and embracing our families in the system as well. So I can see why it's a challenging thing to try to quantify, but to your point, intuitively, it makes absolute sense.
But I think that's the value of bringing groups together like this. The solutions are out here. You all see it. You know that you're spending a lot. It's inefficient. People are bouncing back. You have entrepreneurs, and you see it. And I think that, pulling people together like this, Sarah, this is fabulous because you put the problems right out there in front of us and you see them, and we can see them and name them, we can fix it. And it's going to happen, from people in this room talking about stuff like this. Do we have an answer? No. Are the answers there? Absolutely.
Yeah. Well, and I was even saying when I talked to Jannine this week is, like, there's the shortage of OBGYNs is absolutely being felt in Kentucky, in southern Indiana, like where I practice, and also some of our state laws have influenced our recruiting efforts. I'm not getting political when I say that. I'm just speaking truth about recruiting people even into our state to work that are women's services providers. And so currently there is about a 6-month wait to get a new patient appointment within our health system. And so, it is hard to probably have the general mainstream physician maybe embrace partnering with like an outside company like Electra. But I said to her, like, a market like this is like absolutely the market because like we actually need help because we can't address all the things. And so I think if there's a way for insurance companies to help incentivize patients to partner, not just with their physicians. I know that that's maybe not conventional and accepted amongst some healthcare providers, but I like to think outside the box and just ultimately get the patient cared for. And I think if you make it easy for people to access care with telehealth visits and virtual care, that maybe women will come into the system that otherwise don't have time to do it. And they got to show up for the mammogram in person for that, but at least if they could speak to someone to coordinate some of the care, that would be helpful.
Mm-hmm. So let's talk a little bit about solutions. So I just recently had an amazing experience. Thanks to Gigi, she referred me to Women's First in Louisville, Kentucky. I would come to Gigi, but I've known her for 25 years since med school, and I didn't feel really comfortable with that. So you referred me over to somebody else, and I didn't know what to expect because she was a nurse practitioner. And I've always seen a medical doctor for my gynecological needs. And so I went to Women's First, and I had a consultation, and Audrey Fenwick, amazing, just did a general consultation with me, set me up for an appointment. I went back, and I just thought I was going for a mammogram. Like, I just thought I was going in, gonna have a mammogram, I was gonna be in and out, all good. I had a mammogram, cervical cancer screening, bone density, blood work. There's something else that they did to it, I can't remember, but they did so many things all in one setting. The most comprehensive, coordinated care I've ever had in my life. Nurse practitioner followed up with me at the end. She counseled me both physical, gave me my results, mental health, we talked about a few things there, and I was blown away. It was amazing. But I had my own bias that I didn't think I wanted to go to a nurse practitioner. I wanted to see a medical doctor, and it worked out beautifully, and I'm so happy that I did that. So I think there are some solutions out there that maybe we're not as open to, and I'd love to hear your all's thoughts on how we could push the limits a bit on how I know Electra is doing that every day. So any other thoughts around this?
We have fantastic nurse practitioners that we work with, and we do see a lot of folks, I think, just embracing that in the NP community or the APP community, wanting to be able to care for their patients over the spectrum of their lives. And so just in terms of, there's not a accreditation for menopause, but there is the Menopause Society as a medical society, which offers a test, and it's actually quite rigorous from what I understand. I don't think I could pass it. But we see more and more primary care docs, women's health nurse practitioners entering that space, and I think that that's an excellent thing. We need more and more providers to be able to take care of folks across their lifespan, so I'm thrilled you had that experience.
I think that we're at a pretty mature part of the business cycle in medicine. A lot of the products and services are commoditized, which is great. We know if your cholesterol is high, you see somebody. We know if the colorectal cancer screen is positive, see somebody. So I think that the consumer is going to be the one that decides, I don't want to spend $5,000, of my, deductible to go see this person. If it's $100 over here, I'll spend $100 because that's all I need. Now, if I want to, have a virtual visit, that's fine. I think we've demystified this, and I use that word a lot, to make it easy and available. I mean, what's in Gigi's head, she's got a lot of stuff in there. With all the medical knowledge, that's great. How often do we really need that? Not very much. I think that, seriously, I mean, and I think that the use of ancillary, providers, they're top notch. They're, smarter or better or actually more attentive to the patient than we could ever be because we're thinking about, a delivery or maybe about somebody who has sepsis in the ICU or whatever. So they're more available, and I think that that's where we're going to go. We realize that when I need to get top-notch care, I'm going to go to a specialist, but for the most part, we're healthy. We're not sick. So let me, as a doctor, reassure you about your health and well-being and get you into those care pathways. And I think that's going to, lower the overall cost of care, but we have to do something because, again, like the cost of doing nothing where you miss things and they crash into the emergency room, it's bad. We catch it early, we can treat it and cure it. Catch it late, it's different. So I think that's the way you manage it.
Well, and interesting, a couple concepts that that we're doing at Norton Healthcare, like 2 different strategies to help with combating some of these things are, first of all, that we recruited women's cardiologists into our health system that are specific for women and that have special training. And so we actually have 3 of those providers now in our health system that just focus on women's cardiology health. And we have partnered and encompassed that, even bringing it back to obstetrical space and prenatal visits where people have hypertension and preeclampsia and diabetes, and we're getting them dialed into our women's heart health program, even at that early age. And I say early, but also a lot of women are having babies in their late 30s and 40s. And so we're connecting them into the system early with cardiovascular health and support and establishing that relationship. So I'm excited to see long-term the impact on that as well for our patients. And then the second space of what we're trying to strategize and do is we're in the middle of developing a women's whole care program to where we'll have a gynecologist who specializes in menopause and perimenopause, in addition to partnering with an internal medicine or primary care doctor in the same space, in addition to mammography, in addition to physical therapy, pelvic floor, and urogyn. And trying to have all of that in one space for one-stop shopping and bringing over our women's health cardiologist specialist also, so that when we are identifying women at risk for cardiovascular complications, that they're there as well as part of like that whole comprehensive approach. It's going to be called the women's whole women's care program. And so we're in the middle of that right now. Hopefully that'll be launched here in the next year to hopefully appeal to women in this way that we're talking about.
That's wonderful. So I know we're going to wrap up soon, but we've got this captive audience here. Anything that you want to leave everybody with, thinking about women's health, perimenopause, menopause, what they can do to help?
Well, I'll say something funny. When I got here today, I went over to the old Abbott Tavern over here and had lunch, which that place is historic and great if you guys have time. And I was talking to my fiance, and he said, "So what are you talking about today exactly?" And I went into it and I said, and I'm going to share some of my experiences over the last few years myself as well. And he goes, wait, you're menopausal? So I'm like, you know how you don't want to touch me at night, or how my hair fell out, like, and so, I mean, we hadn't really had a lot of conversation, I realized. So I don't know, I hope that just today, this conversation, even for people that haven't understood all the changes, you could support your friends and partners as they're going through it.
That's awesome.
So having been raised by the nuns, I always think about Sister Claire. And I was asking her about St. Agnes Hospital, how she pays for all this. And she says, Pat, you know, the mission is always first, and the mission is care. The money comes later. And I think that as long as we navigate with care at the core of what we do, you know, that human condition, the money will come. But we need to be thoughtful about that, and we need to drive those discussions, you know, about this return on investment and reframe it to care for the individual. And that's, you know, that's our responsibility, everybody in this room, is to really push hard for the care, because the money's there. We've got, you know, trillions of dollars in healthcare. Somebody can figure out a way to get in front of that. Okay, great. But I do believe that the work everybody's doing here, you know, focus on the mission. Thank you, sister. You know, and keeping care at the core of what we do is really going to make a big difference.
I think that this team has been doing, you know, walking the walk. You're having this conversation, the keynote panel, opening this address. So I guess I would say to everybody, reflect on that later, and perhaps, you know, in your own lives, think about your, you know, family, your friends. This is a conversation that includes everybody. Yeah. It's not just specific, as you know, Pat said, to women who are of a certain age, and we're living longer. So we're going to be postmenopausal for a long time. And so I think this is just universal, and I hope that that's the one takeaway is go and speak to somebody else in your life about this topic, like Gigi did with her fiance.
That's hilarious. But
3
thank you.
years in.
A taboo subject.
Wow, that's amazing. I cannot thank you all enough. This has been an incredible conversation. What a way to open the Connect conference this year. I truly appreciate it. Thank you.
Let's go do something with it.
Thank you.
Thank you.
Thank you for
Thank
what
you
you
very
do.
much.